Here's some notes on damage control resuscitation. This is a method that was initially developed by the military in 2004. Its goal is rapid bleeding control, and it might involve the use of tourniquets, pelvic binders, and splinting for long bone injuries. The initial focus is on controlling hemorrhage before definitive surgery. There's some notes on blood product management. You want a balanced transfusion ratio of 1 to 1 to 1, fresh frozen plasma, platelets, and packed red blood cells. Your goal is to mirror whole blood composition. TXA plays a role. It prevents fibrinolysis by blocking plasminogen conversion to plasmin, and early administration of TXA can reduce mortality in hemorrhaging trauma patients. In some cases, you might want to do permissive hypotension with a target systolic blood pressure of 80 to 90 in adults. This reduces bleeding from uncontrolled sources. There are some contraindications to permissive hypotension. You don't want to do it in traumatic brain or spinal cord injuries or in elderly patients with chronic hypertension. You don't want them to be hypoperfusing their brain or essential organs. Some notes on crystalloid management. You want limited use of crystalloids and you want to avoid aggressive crystalloid administration. The rationale here is that it prevents dilution of clotting factors. If you were to give a bunch of crystalloids, you might dilute your existing clotting factors, and you need those as much as possible to prevent coagulopathy. Notes on temperature management. You want to make sure the patient is actively warm and you want to prevent hypothermia. This minimizes the operative time to reduce hypothermia risk. And of course, your clotting is worse with hypothermia. So lastly, some goals on damage control resuscitation. You want to maintain tissue oxygenation, prevent complications like abdominal compartment syndrome, ARDS, coagulopathy, multiple organ failure, and pulmonary edema.